Good afternoon. I'd like to thank SAGES for the invitation to present. Today, I'll be discussing the effect of neoadjuvant chemoradiation on anastomotic leak and additional 30-day morbidity and mortality in patients with gastric cancer. We have no disclosures for this presentation. Recent randomized controlled trials have demonstrated a survival benefit for patients with gastric cancer who receive perioperative chemotherapy and radiation therapy. Nevertheless, the utilization of such therapy remains low in the United States, with just over 20% of eligible patients receiving such therapy. One factor that may lead to decreased enthusiasm for preoperative chemotherapy and radiation therapy is the concern for anastomotic leak and additional postoperative morbidity and mortality. Which leads us to the purpose of our study, which is to investigate the association of preoperative chemotherapy and radiation therapy on the incidence of anastomotic leak and additional 30-day morbidity and mortality in patients undergoing gastric resection for gastric cancer. In order to do this, we use the ACS-NSQIP database from 2005 through 2012. All patients undergoing total gastrectomy, including esophagoenterostomy, Roux-en-Y reconstruction, and intestinal pouch creation for gastric cancer, were included in our analysis. These patients were identified based on the combination of the CPT code for the procedure performed, as well as the ICD-9 code for the location of the gastric cancer. Patients undergoing emergency surgery, patients with distal esophageal or GE junction cancer, patients without the appropriate CPT and ICD-9 code combination, patients with disseminated cancer, and patients undergoing total gastrectomy for any indication other than gastric cancer were excluded from our analysis. Preoperative patient variables, intraoperative variables, and 30-day morbidity and mortality were investigated using a variety of statistical tests. 3 comparisons were made. The first comparison was between those patients who experienced an anastomotic leak and those who did not. The second comparison was between those patients who underwent either preoperative chemotherapy or radiation therapy versus those patients who received no neoadjuvant therapy. The last comparison was between those patients who underwent both preoperative chemotherapy and radiation therapy versus those patients who received no neoadjuvant therapy and those patients who received either preoperative chemotherapy or radiation therapy. The primary outcome of interest include the incidence of anastomotic leak, which is identified as an organ space infection within the NSQIP database. This definition includes duodenal sump leaks, esophagojejunostomy leaks, jejunojejunostomy leaks, and staple line leaks. The secondary outcomes of interest included composite cardiac, pulmonary, wound, septic, renal, and clotting outcomes, as well as the incidence of unplanned return to the operating room and 30-day mortality. A total of 1,135 patients met inclusion criteria. 98 of these patients experienced an anastomotic leak. There was no statistically significant difference between the two groups in terms of the number of patients who received preoperative chemotherapy or radiation therapy. With respect to patient demographics, patients who experienced an anastomotic leak had a significantly higher average BMI and were more likely to have a preoperative wound infection. Again, there was no statistically significant difference between the two groups in terms of the number of patients who received preoperative chemotherapy or radiation therapy. With respect to operative variables, there was no statistically significant difference between the two groups in the procedures performed. However, there was a statistically significantly higher operative time for those patients who experienced an anastomotic leak. Next, we compared those patients who received either preoperative chemotherapy or radiation therapy to those patients who received no neoadjuvant therapy. Those patients who received no neoadjuvant therapy were significantly more likely to experience a pulmonary event, including pneumonia, reintubation, and prolonged intubation. Finally, we compared those patients who received both preoperative chemotherapy and radiation therapy to those patients who received either preoperative chemotherapy or radiation therapy or no neoadjuvant therapy. The number of patients who received both preoperative chemotherapy and radiation therapy was quite low. Nevertheless, there was no statistically significant difference between the two groups in terms of the incidence of 30-day morbidity and mortality. In conclusion, the use of neoadjuvant therapy for gastric cancer remains low in the United States. 2.5% of our patient population received both preoperative chemotherapy and radiation therapy, while up to 15.3% of patients underwent chemotherapy alone. Nevertheless, the delivery of neoadjuvant chemotherapy or radiation therapy is not associated with an increased risk of anastomotic leak or additional 30-day morbidity and mortality.
Thank you very much. Now, yes, please.
Ziad Awad, University of Florida. So let me ask you this question. How accurate is this NSQIP data collection, in your honest opinion? Number one. Number two, do you think the NSQIP data give you timing for chemotherapy? And is it synchronous with radiation therapy? The answer is no, because we looked at this. So the timing for the patients who last got their chemotherapy dose was 30 days. And radiation is more than 90 days. So you cannot draw a conclusion based on these non-homogeneous groups. My opinion would have been good to look at chemotherapy alone versus none, because this is the most widely used regimen in the United States, ECF, ECX, FOLFOX, blah, blah, blah. But you cannot make 4 groups together to reach a conclusion.
Thank you.
Okay, please.
Hi, Vanziali, Hershey, Pennsylvania. One question regarding sort of the use of this data set and the utilization of combined chemoradiation preoperatively. You'd commented that the utilization nationally is very low. So I was wondering what you thought about selection bias in terms of your outcomes for perhaps specialty centers that are utilizing both chemoradiation, and perhaps that's a confounder for the actual benefit in terms of outcomes.
Yeah, that's a great question. So we did think that perhaps there was a selection bias. However, there was no difference in the ASA class or functional status for patients who did or did not receive chemotherapy or radiation therapy. So, you know, we think that this data is valid to say that at least in the United States, it's reflective of the pattern. We only included the NSQIP up to 2012 because after that, it's not reliably coded like the previous speaker mentioned.
Thank you very much.